How do I define CLI? CLI is a state where a limb is threatened to become amputated. That's the general definition. This can include states of rest pain during nighttime in particular, or slowly or non-healing wounds. Well, the first three steps of the evaluation of CLI patients in our institution, but I believe globally, are the following. First of all, it includes the patient's history, the recording of that, a clinical examination so that you get an overview about potential wound locations, the degree and severity of such wounds. It's documentation of pulses and skin temperatures. And the second step is non-invasive diagnostic workup, including ABI measurement, even if this is not very sensitive in this patient population, followed by oscillometry. And then finally, every patient in my institution receives a duplex examination. And with this workup, we can at least identify the level of the perfusion deficit and decide which is then the next step. Will the patient undergo then a non-invasive angiographic workup, including CT or MR, or if we are going directly into the cath lab for a diagnostic angiogram in readiness for an interventional procedure. Well, the question is there a role of medical therapy in CLI patients? Of course it is, but this is not different between claudicants and CLI patients or other patients suffering from atherosclerotic diseases like coronary artery disease. That means basically it's secondary preventive therapy, so every patient receives an antiplatelet drug. The Capri trial has shown mild superiority of clopidogrel over aspirin, and otherwise the patient receives statins, blood pressure lowering agents. If a patient is suffering from rest pain, obviously he gets some analgesics. So what we do not administer are prostaglandins. In recent studies they have not shown to be beneficial even in CLI conditions, so that's something we have skipped completely in our institution. So we rely basically on reperfusion strategies where possible. Well, basically my personal policy is to aim for a complete as possible revascularization of the affected limb, depending a little bit on the localization of the wound. That means that before I start the revascularization procedure, I try to analyze which vessel does provide the affected skin area. And if possible, I try to reopen this vessel first. If not, then I'm going to reopen those vessels that provide indirect flow. And as mentioned, the idea is to open as many vessels as possible. That can be that this is necessary in a stage procedure. It depends a little bit on the complexity of the intervention. Well, regarding the development of the incidence of amputation, my belief is, and this has been shown just recently by analysis of amputation numbers also in the US, that the number will decrease. There's already a mild trend also in Europe, and the reason for that is manifold. One of the reasons definitely is that the awareness of the background of non-healing wounds did change during the last decade, in terms of that the underlying vasculopathy is now examined more in detail before decisions about amputations are made. So that means the diagnostic workup is in most cases now the first step before you decide whether it's really necessary to amputate or not, and if possible, revascularization strategies are applied more frequently, and that's, in my opinion, one of the major reasons for the reduction of amputations, not only already today but also in the future.